Okay, so just a second. The scan, then officially. Yep. Okay, just a minute. Now it must be perfect. Yes. So, yeah, welcome. This is another stream where I continue. Actually, well, technically today morning. Today morning I just stopped it off in between. I wasn't. Uh, I had kept a timer to wake up, but I just slept off. I genuinely just slept off the entire time. So yeah, today I will study till 12, which is tomorrow, technically. And I hope, yes, I can get started right now. So I had left off when I believe stomach. So I just started doing stomach. Yes. So stomach and duodenum. So first, let me just bring up. Bring up 1 second. I just say which and all topics are important. So I got my singy right here. And let's see, general surgery, stomach you need to study. um, Gallbladder, spleen, pancreas, normal umbilicus. Yeah, start. Stomach. So you have see. So the topics are first you peptic ulcer first of all. Then after peptic ulcer you have stress ulcers, ramjet operation. Yeah. So peptic ulcer, I have to do. Then duodenal ulcer. Then operations and all, and sequel where hematemesis, hematemesis. Uses of hematemesis. How do you manage case of hematemesis? Secondary bleeding pelvic ulcer, pre-malignant risk factors of carcinoma of stomach. Okay, CA stomach. And these are all the 10 markers which you'll get. Then for 5 marker and 3 markers, you have blood supply, anatomy of stomach, gastroscopy, H. pylori, then stenosis, pyloric stenosis, then operation. I'll just write Rams steroid, but I'll just see it's already inside one of these operations. Pyloric stenosis, gastric ulcer, perforated peptic ulcer, apogea bleeding, dumping syndrome. Trichoepizomore stomach. I don't know what this trichoepizomore is. Okay. Volvulus stomach. Linitis plastic. Gist. Gastrointestinal stromal tumor. gastrointestinal stromal tumor, GIST. Very good to me. Plus types. Then, okay, just a second. Okay, sorry for the interruption. So we have another few topics. We have to do barium meal, then proton pump inhibitors, and after that you have trichovisor, gastric polyps, gastric polyps, and after that Krokenberg tumor. I think this is what do you say? Ovary, cervix. It's spread to cervix, no? Sister Joseph, nodule, incusplentical which was lymph node, varicose, lymph node, double contrast study. I think this double contrast is not that important, but let's just I'll do it again. So these are all the topics which I have to do, and let's get started. So first we have surgical anatomy. So esophagus continues from esophagogastric junction as a muscular tube, which is the stomach. Then fundus. It is a part of the stomach where it projects upward and lies in contact with the left dome of the diaphragm. It is usually full of gas. Significance. It is to identify the site, right or left of the body in a plain X-ray abdomen. Then in achalasia fundic air bubble is absent. I have no idea. They didn't mention this in achalasia. Fundic wrap is used in hiatus hernia. Then during mobilization of the fundus, splenectomy or other upper gastric surgery, short gastric artery need to be divided. If the ligatures are too close, then the stomach near the fundus is close to the stomach near the fundus. The gastric fistula may occur due to necrosis of the ligatures too close, then it causes necrosis of the stomach. Then GIST, gastrointestinal stromal tumor, are common in fundus. But it extends from the so under fundus is the part which protects upwards. I'll just mention that also. Projects upward and is in contact with the left dome of the diaphragm. Yeah, do we have to? It's generally assumed to be full of gas. No, it's okay. And this is not that significant. Let me zoom in a little bit. Okay. So the body extends from the fundus to the insula angularis. So I think insula angularis you don't remember. Fundus is a very broad term which you can easily remember. It has lesser curvature and greater curvature. Then significance. It has the ability to have a meal is due to receptive relaxation of the body of the stomach. Greater curvature is located at the level of the umbilicus. Then classical gastrojejunostomy (GJ), anterior or posterior, involves using the body of the stomach. Posteriorly, it is related to lesser sac pancreas. Carcinoma of the body may infiltrate the pancreas. It necessitates careful dissection to separate the pancreas. So classical genostomy, anterior posterior, involves the body of the stomach, leave it. Gastric curvature located at the level of umbilicus. Again, not important. Posteriorly, it is related to the lesser sac, pancreas. Carcinoma of the body may infiltrate pancreas. Okay, none of this seems significant. Maybe this first point may be significant. Like that, I cannot remember any of them. Pyloric antrum, it extends from the insula till the pylorus. Pylorus is thicker than the rest of the stomach. It is the sphincter. It is a sphincter of circular muscle fibers. Its canal is usually closed. So, significance. Pyloric antrum is a common site for gastritis, ulcers, and carcinoma. That's it. Incompetence of the sphincter results in severe duodeноgastric reflux in close contact with the head of the pancreas. During gastrectomy, avoid extend care to be taken to mobilize the region of antrum to avoid bleeding the pancreatic head region. During gastrectomy, extreme care has to be taken to mobilize the antrum to avoid bleeding the pancreatic head region. Actually, I think related to lesser and pancreas carcinoma of the main way to affect is pancreas. This one may be important. Okay. Insula angularis that you don't get. Then greater curvature, it lies in contact with the transverse colon and gastrocolic omentum. It has to be divided from the transverse colon during gastrectomy, which is done for carcinoma also. So yeah, you can see these. Is there anything important? I think this greater curvature, it lies in contact with gastrocolic. Yeah. It has to be divided separately. We can just assume. Then lesser omentum is lesser omentum. It is a double layered structure. It is suspended between the lesser curvature of the stomach and the proximal 0.5 inches 2 centimeter of the first part of the duodenum inferiorly and the porta hepatis and the fissure of the ligamentum venosum superiorly. The lesser omentum is divided into two ligaments. You have hepatogastric and you have hepatoduodenal. Location within the lesser omentum are hepatic triad, branches of anterior vagus nerve, some lymph node, and left gastric arteries. Double layered structure. Then vagus nerve. The right and left vagus nerve descend parallel to the esophagus and form esophageal vagus plexus between the level of trachea bifurcation and level of diaphragm. From this plexus, two vagus trunks, anterior and posterior, pass through the esophageal hiatus of the diaphragm. So you have a mnemonic which is LARP. Left trunk is anterior gastric wall, right trunk is posterior gastric wall. It will supply from the plexus. So there's a plexus, from that LARP. Left trunk is anterior, right trunk is posterior. So greater omentum, it is named as a policeman of the peritoneal cavity. It exhibits protective action in the inflammatory process and perforations. Omentoplasty, omental wrapping of anastomosis may decrease the occurrence of anastomatic leak when esophagogastric anastomosis is performed for cancer of esophagus or in the closure of duodenal perforation. It has many important applications and can be used for colorectal surgery, reconstructing of irradiated pharyngeal wounds, and packing of bleeding liver wounds. Then it is used to treat peripheral vascular diseases such as TAO. It is total arterial obstruction, I think so. Aortic obstruction, wherein direct artery surgery is not possible. So peripheral vascular disease also it can be used. It becomes enemy when it is involved with metastasis though, as directly by malignant neoplastic processes from ovary or colorectal cancer. Omentum is one of the most common site involvement in TB also, and omentum itself can act like a band which causes intestinal obstruction also sometimes. And then blood supply, you have celiac trunk and it is branches. You have to remember that much. So there are 5 arteries which is remember. The main is left gastric artery. It is the direct branch of the celiac trunk. It ascends up to the esophageal hiatus and turns to the right along with the lesser curvature of the stomach. It branches and anastomosis with the branches of the right gastric artery and supplies anterior and posterior wall of the stomach. It is a true anastomosis between the branches of left gastric artery and the other branches. So, supplies into the posterior stomach. This is the only point which is important. Left gastric artery is okay, maybe direct branch also may be important. So it is a branch from celiac artery. It branches an anastomosis with branches of right gastric artery and supplies anterior and posterior wall. Then you have the right gastric artery. It is a branch of hepatic artery. It comes from celiac trunk. It supplies lesser curvature and body of stomach along with the left gastric artery. This entire thing is important. Then left gastroepiploic artery. It arises from the splenic artery and supplies the greater curvature. Anastomosis with the right gastroepiploic artery. And there is also the right gastroepiploic artery, branch of gastroduodenal artery, which is a branch of hepatic artery. Then short gastric arteries are the branches from splenic artery. They supply the fundus of the stomach, also called vasa brevia. Actually, this entire thing is very very important because this you don't have to know till where the course you don't have to know, but you have to be knowing where it's coming from and what it is supplying. Actually, yeah, maybe better to just a second. So venous drainage is runs from the corresponding arteries only, and right and left gastric vein drain into portal vein directly. Epiploic vein joins superior gastroepiploic vein. Right and left is portal vein. Right gastroepiploic vein and joins the superior mesenteric vein. Left gastroepiploic vein and vasa brevia join the splenic vein. Pyloric vein of Mayo is usual guide to the junction between stomach and duodenum. Actually, yeah, this entire thing is important. Surgical importance. Because of extensive anastomosis of blood vessels, extramural and intramural collateral vessels, stomach can survive with right gastric and right epiploic artery. Left you can remove it. Thus, stomach can be used to replace the entire esophagus after esophagectomy, which is called gastric pull-up. The order of ligation of blood vessels in gastrectomy is as follows: left epiploic, gastroepiploic, right gastroepiploic, then right gastric when the stomach is divided, then the stomach is divided. Lastly, then you divide the left gastric artery. Okay, this order might be important. Gastroduodenal artery, a branch of hepatic artery, runs behind the first part of duodenum and divides at the right gastroepiploic artery and superior pancreaticoduodenal artery. So, it is this artery which bleeds when the posterior duodenal valve erodes it. It could come back later. Posterior superior right gastroepiploic artery and superior pancreaticoduodenal artery. Maybe wait one second. Posterior duodenal also erodes into it. I'll just make this one. No, I think it'll come up. I don't want to mark it here. It'll come up. It'll mostly come up. Then lymphatic drainage is an important pathway for spread of cancer of the stomach. Spread occurs through both emboli and permeation. Right gastric nodules, supraploic nodules mainly drain the pyloric antrum. Actually, this entire thing is very very confusing. Actually, I think even this one also might be not that important. But the origin you may require, because here there is no origin, there is no course, there is only parts which is being drained. Better than that, you can just remember this one image. We can just remember the names and just assume a little bit. This I feel is the only thing which is important. So superior gastric groups So okay. Right gastric tube or suprapyloric nodules mainly drain the pyloric antrum. This is the antrum, and mm, subpyloric nodule, gastropyloric nodule, right, drain the greater curvature of the stomach. Left gastropyloric nodules, splenic nodules drain the critical splenic nodules is there, drain the curvature. Splenic nodules drain the upper portion of the stomach, mainly fundus, carcinoma of the fundus. Left gastric superior nodules drain the lesser curvature and body of stomach. Superior gastric group of nodule. Celiac nodule receive lymph from the entire forehead. I think this is the only important point. Yeah. Left gastric, superior gastric. You don't remember all of this. This is the only thing. So, which drain directly into the cisterna chyli and the thoracic duct. Later, mediastinal nodes and left supraclavicular virtual nodes are involved. Yes. Okay. This they'll again discuss whatever is important in the carcinoma of the stomach. Then lymphatics of stomach. You have intrinsic network, intrinsic network, extrinsic network. So the submucosal lymph plexus is perhaps richest in anastomosis. Upward invasive spread of gastric cancer to the esophagus is common. Downward mucosal or submucosal invasion of the duodenum is not common. Lymphatics of the stomach, you have intrinsic lymphatic, which is submucosal lymphatic plexus, which is perhaps richest in anastomosis. Upward invasive spread of gastric cancer to the esophagus is common, but downward mucosal submucosal invasion of the duodenum is not common. Gastrectomy with distal esophagectomy is done for carcinoma of the proximal stomach. Yeah, this might be important. Upward invasive spread of gastric cancer too is common, but downward is submucosal invasion of the duodenum is not common. That's why you get distal esophagectomy is done in carcinoma of the proximal stomach. Yes. Okay. Then extrinsic network, you have extrinsic lymphatic vessels of the stomach follow the gastric veins. So drain to the perigastric lymph nodes, which drain into the lymph nodes located at the celiac axis, which again drain into lymph nodes located at the celiac axis. Then superior gastric group drains lymph from the nodes upper lesser curvature into the gastric and pericardial nodes. Then let's see. Suprapyloric group of nodes drains the anterior segment of the lesser curvature of the stomach into the right suprapyloric pancreatic nodes. Pancreatico-lineal, renal, pancreatico-renal group of nodes into the lymph. None of these seem to be very important. Yeah, none of these are important. It just says a lot of words. You won't even remember this. I'm telling you, it's not important. Okay, so that is the anatomy which has been done, which I feel is important. If carcinoma of stomach tells me that some other points are important, I'll just learn it there only. Then, so anatomy of the stomach is done. Physiology, gastric physiology, hypergastrimia, various causes of incision, surgical interest, or ulcerogenic causes, non-ulcerogenic causes. You can remember this, like ulcerogenic causes, you have ventral G cells, Zollinger-Ellison syndrome, retained excluded antrum, gastric outlet obstruction, shortcut syndrome. Then non-ulcerogenic is anti-secretory proton pump inhibitors, and atrophic gastritis, pernicious anemia, acid reducing procedure, vagotomy, Helicobacter pylori infection, and chronic renal failure. These people have mentioned hyperglycemia and gastric acid secretion. So, simulation of gastric acid is regulated by three local stimuli: acetylcholine, gastrin, and histamine. Just a second. Then these stimuli account for basic basal and stimulated gastric acid secretion. Acetylcholine is the principal neurotransmitter modulating acid secretion and is released from the vagus and parasympathetic ganglion cells. So, vagal fibers innervate not only the parietal cells but also the G cell and enterochromatin-like cells to modulate the release of their peptides. Gastrin has hormonal effect on the parietal and stimulates histamine release. Histamine has paracrine-like effect and the parietal cell. It's on the parietal cell and its release from extra enterochromatin like cells is plays a role in the regulation of acid secretion by parietal cells. Then ingestion of meal simulates vagal fiber to release acetylcholine, which leads to again cephalic phase. Binding of acetylcholine to parietal cell and G cell results in release of histamine, hydrochloric acid, and gastrin respectively. Acetylcholine also inhibits somatostatin release by inhibiting extra ECL enterochromatin like cell. Then following the male G cells to stimulate. So cephalic phase. Okay, I need to break this down just a second. I honestly I didn't understand what hypergastrimia is. Hypergastrimia. Hypergastrimia, it occurs when the levels of hormone that helps in digestion are higher than normal. Since inside the lower part of the stomach lining near the small G cell produce gastrin. So, okay, it basically means increased level of gastrin. It may cause diarrhea, belly pain, and other symptoms. That's it. Yeah. So you can do pain inhibitors, anti-secretory, non-acetylcholine. Yeah. Okay. So gastric acid secretion, three important points. You have acetylcholine, gastrin, and histamine. Acetylcholine is principal neurotransmitter released from vagus and parasympathetic ganglions. Then it also two cells, G cells and enterochromatin type cells, like cells. And gastrin has hormone effects on parietal and stimulates histamine release. Histamine has paracrine-like effects on the parietal cell and its release from ECL cells plays a central role in the regulation of acid secretion by parietal cells. Then you have cephalic phase, which is and then you have binding of acetylcholine to parietal cells and G cell, resulting in release of histamine, hydrochloric acid, and gastrin respectively. Binding of acetylcholine leads to histamine, hydrochloric acid, and gastrin secretion. Acetylcholine also inhibits somatostatin by inhibiting E enterochromatin cells, like cells, enterochromatin like cells. So histamine is secreted by ECL. G cells secrete gastrin, yes, that much is correct. Histamine and hydrochloric acid is parietal cells. Yes. Acetylcholine also inhibits somatostatin release. Yeah. By inhibiting ECL. Then, following a meal, G cells are also stimulated to release gastrin. which interacts with the receptor located on UCL cells and parietal cells to cause the release of histamine and hydrochloric acid, which is gastric phase. These are similar to release gastric, which interacts with receptor location on UCL cells, release of histamine and hydrochloric acid. There's also D cells. D cells, man, where they are. It is in ECL. Enterochromaffin like cell. And somatostatin exerts inhibitory effect on gastric acid secretion. 1 second. Yeah. Then release of somatostatin. Okay. After it's release of somatostatin from antral D cell is limited in the presence of intraluminal acid pH of 3 or less. After its release, somatostatin inhibits gastric release through paracrine effects and is also modified. And it also modifies histamine release from UCL. Okay, so just a second, I have an order coming in. I'll be right back. Just 1 second. Gastric acid secretions. It's very hard to remember this, but you will have to remember this for NLP anyway. Yeah, I gotta run. I'll be right back. Okay, chat. We got food. Now, I don't really know what else to do. I think I'll just eat a little bit. I'll probably take a small break. I'll honestly, yeah, is there a good finishing point? Yes, there is. So gastric secretion, acid secretion is. I'll try to finish at least until Helicobacter pylori infection, and I'll eat my dinner. Then acid secretion is 150 to 160 milligram per liter. Oxygentic cells, principal cells, the type A is parietal. And the location is fundus in the body, and functions is cephalic, vagus. Gastric is gastrin and intestinal. Okay, mucous cells are columnar epithelium, and the entire stomach will be lined. Intestine is not clear. Luminal cytoproduction from acid, pepsin, and ingested substances. Pepsinogen 1 and 2 done by chief cell located in deeper areas of oxygenatic gland, and it is located in body and fundus, and its functions are mediator or vagal stimulation. Then mucous gastrin is antrum, located in antrum, and it is cytoproduction. Bicarbonate is done by mucous cells, which is located in the stomach. Vagal stimulation increases the bicarbonate secretion and prostaglandin E2. Intrinsic factor is released by parietal cells in the fundus. It is necessary for absorption of B12 and peptides, histamine, ECL cells, and D cells. Delta is released from fundus and antrum respectively. Then it is release of peptides, and somatostatin inhibits acid secretion. So in some patients with peptic ulcer disease, this negative feedback response is effective. PUD, negative feedback is defective. Consequently, the precise state of acid secretion by the parietal cell dependent on the overall influence of the positive and negative stimuli. Then, function of the gastric gland. Gastric acid plays a critical role in the digestion of a meal, required to convert pepsinogen to pepsin, which is necessary for hydrolysis of proteins into polypeptides. Gastric acid elicits release of secretin from the duodenum, which results in pancreatic bicarbonate secretion. In addition, gastric acid functions to limit the colonization of the upper GI tract with bacteria. Limit the upper GI tract and bacteria. Release of secretin from duodenum, which results in pancreatic bicarbonate secretion. Gastric analysis you do, there is aspiration of the gastric contents through an esogastric tube is the most accurate. Then it requires a complete emptying of the gastric contents followed by instillation and recovery of 50 ml of saline. Stomach is aspirated every 5 minutes for 1 hour, and aspirate is pulled in 15 minutes like cards. At the end of an hour, stomach is stimulated to secrete acid by IV administration of secretogenics such as histamine, pentagastrin. Aspiration of the stomach continues with 15 minutes collection over 1 hour period. Then volume of the collection is measured, and rate of secretion is expressed in millicurrents reduced per hour during the basal unstimulated state and during maximum and peak acid output. Maximum acid output is obtained by averaging the output of two peak output is highest rate secretion. Okay, this might be important. I don't think so. Pre-motility agents that accelerate gastric emptying, and these are metoclopramide, domperidone, erythromycin, metronidazole, neostigmine. The method is generally dopamine antagonist and motilin antagonist. There's also cholinergic, which is betlamethasone and neostigmine, physostigmine, neostigmine, and all. They are cholinergic agonist. They increase acetylcholine and the entire all of these pathways. Okay, so after the break, I'll do H. pylori infection. I'll take around 15 minutes. I'll keep myself in chat in case somebody else joins. They can see and understand what exactly happened. Then, what is it? Break of 15 minutes. Start stream. Having food. Stream continues after 7 p.m. see. I have sent a message. Yeah, I'll be right back. Just 1 minute. Okay, so I'm back. Yeah, and I still have a bit of ice cream to eat. I'll do that, and I'll teach a little bit too. Mm, yeah. Or here. Yep. I had to take this thing too. And yeah. Okay, so let's start with H. pylori infection. So H. pylori is established that 90% of duodenal ulcer and 75% of gastric ulcer are associated with H. pylori infection. Warren and Marshall were the first to identify this uh, isolated organism, originally referred to as Campylobacter pyloritis. Mm. It is a spiral or helical gram-negative rod with 54 fibula, gastric type epithelium within or beneath the mucous layer, which protects it both from acid and antibiotics. 90% of renal ulcers, 75% of gastric ulcers. And then its shape and flagella aids its movement through the mucous layer, and it produces a variety of enzymes that help it to adapt to a hostile environment. Most notably, it is one of the most potent producer of urease amongst any bacteria yet discovered. Mm. Enzyme is capable of splitting urea into ammonia and organic carbonate, creating an alkaline microenvironment. This alkaline Mm. It makes a microenvironment. That's the only important thing which you know. Mm. So there is specific adherence in vivo that can be recognized by the organism. So only gastric epithelium will be living, but sometimes in ferrets also. So in metaplasia in the duodenum and mucous diverticulum, and in heterotrophic gastric mucosa in the rectum. So mechanism responsible for H. pylori induced gastric GI injury is not very clear, but three potential mechanisms have been proposed. Production of toxic products leading to local tissue injury, induction of local mucosal immune response, increased gastrin levels with a resultant increase in acid secretion. Most H. pylori strains is circulating cytotoxin, which is the back aerotoxin causes release of cytokinin C form. Mitochondrion induces apoptosis. Back aerotoxin. Mm. Mm. Mechanism of Helicobacter pylori induced injury is Helicobacter gram-negative bacteria. So it produces urease, which splits urea, resulting in bicarbonate, which creates alkaline environment. Another enzyme mucinase, which degrades mucosa. It lives only in the gastric epithelium. Its injury is due to toxins such as vacuolating cytotoxin. You have increased gastrin levels, phospholipids will be there, and platelet activating factors will be there. Increased immunoglobulin response. Hope response. Sorry. Host response is seen. Then cytotoxins will be there. Other factors, including local tissue injury and local ischemia, will also be there. You can remember it as helico. Mm. So H is Helicobacter bacterium. E is enzyme producing urease. L is lymphocytes only in the gastric epithelium. I is injury is due to toxins, increased gastrin levels, phospholipids, platelet activating factor, increase immunoglobulin response, host response. C is cytotoxins, and which is not that important, and O is other factors, local injury and local ischemia. So then, diagnosis. H. pylori infection can be diagnosed by both non-invasive and invasive method. A non-invasive method, you have urea breath test, serology, and detection of antigen in the stool samples. The urea breath test is based on production of urease by H. pylori in the gastric mucosa, and C14 labeled urea is ingestion, and C14 labeled CO2 is produced and excreted in the breath. This test has a sensitivity and specificity of greater than 90% and indicates ongoing infection. If the urea breath test is useful for initial diagnosis of infection and for follow-up after eradication therapy, it's useful for those things. Then, invasive methods. Patients should undergo endoscopic diagnosis and is indicated in the following situation. Patients more than 50 years of age, they are those with significant symptoms including gastrointestinal bleeding, anemia, weight loss. More than 50 years old, significant symptoms, gastrointestinal bleeding, anemia, weight loss. During endoscopy, antral biopsies can be obtained and the organism collected in the agar containing both urea and pH sensitive calorimetric agents. So H. pylori hydrolysis of urea causes a diagnostic change in the color. pH sensitive calorimeter, okay. Then the sensitivity of this test varies from 80 to 100% and specificity is more than 90%. Then biopsy also permits histological evaluation with visualization of the organism. Culture of H. pylori is not routine and is usually reserved for recurrent infection and for antibiotic sensitivity testing when second line therapy has failed. You cannot even culture. It's very resistant to living outside the gastric. So treatment: to be effective, antimicrobial drugs must be combined with gastric acid and secretion and inhibitors or bismuth salts. Cure rate of 80 to 85% are achieved using a combination of therapy, usually proton pump inhibitor and anitidine or bismuth citrate with two antibiotics. You have to give several different types of antibiotics because it's very hard to reach. Then the most common antibiotics used are clarithromycin, amoxicillin, metronidazole, or tinidazole. Currently, metronidazole is the mainstay of the treatment. Eradication therapy with the PPI and metronidazole and amoxicillin decreases the prevalence of metronidazole-resistant H. pylori strains. Different regimens: you have bismuth triple therapy. Bismuth 2 tablets 4 times a day. Metronidazole plus metronidazole 250 mg 3 times a day. Tetracycline plus tetracycline 500 mg 4 times a day. You have to give all these drugs. Then you also have PPI triple therapy. One second. I haven't been. Oh my god. Just a second. This is important. And C14 is important. Sensitivity more than independence. Initial and eradication therapy. And invasive methods. Endoscopic diagnosis is 3 things. All these things: weight loss, intestinal bleeding, and all of these. Ventral biopsies can be obtained, which can also then agar containing both urine pH and parametric. Agar containing both this thing. H. pylori analysis is cause diagnosis and specificity exceeds 90%. This is the only thing which is important. And biopsy permits histological examination with visualization of culture of routine, not routine. That's it. Treatment is this is the treatment. And okay. Honestly, regimens you have to do the entire thing. Okay, not required. I mean, yeah, fine. This much is enough. So again, yeah. Tests for Helicobacter pylori, serological test, ELISA based. Patient has not received treatment for respiratory infection. Test of choice is serological. Non-invasive, very high specificity, sensitivity. Urea blood test is very simple, very high sensitivity, specificity. And histological test, silver staining with silver gemisa. Serological ELISA based. And does not confirm eradication because serological positivity returns for indefinite period. False negative possible if done too soon after treatment. Small radiation exposure and cost and availability have disadvantages. And histological test requires laboratory. Name sustain is better. Rapid urease test, simplest. Endoscopy is required. Rapid. Sensitivity 80 to 85%. Specificity is also high. Invasive. False negative possible if testing is done too soon after. Okay, culture not routinely done. Resistance is allows determination of antibiotic susceptibility. That's the only thing which is need to know. rapid urease test. So the names you have to remember all of them. Yes, all of the names you remember and the thing. So you have different types of gastritis. You have type A, type B, reflex, and erosive. Type A, you have autoimmune antibodies to bacterial cells. Type B, you have H. pylori associated. You have reflex after cholecystectomy, gastric surgery, and you have erosive, which occurs due to NSAID. Type A is autoimmune antibodies to parietal cell. Fundus and bodies are affected, atrophy of the parietal cell mass, and hypochlorhydria and decreased intrinsic factor is seen. Hypochlorhydria simulates the antral gastrin and it predisposes to development of gastric cancer. It can give rise to intestinal metaplasia and type B is H. pylori associated. Antrum is affected, predisposes peptic ulcer disease, gives rise to intestinal metaplasia and dysplasia and predisposes to development of gastric cancer. Reflex you have after cholecystectomy, gastric surgery, antrum is affected, does not give rise to peptic ulcer disease, treated by prokinetic agents or bile chelating agents. Erosive occurs due to NSAID, affects entire stomach, occurs due to defective gastric mucosal barrier, treated by H2 blocker or proton pump inhibitors. Type A autoimmune is prone to gastric cancer. Type B is intestinal metaplasia dysplasia of gastric cancer. Same thing, huh? Oh, wait. No. Peptic disease. And it causes hypochlorhydria and decreased fundus and body are affected. Autoimmune antibodies to the parietal cells are antrum is affected and give rise to intestinal metaplasia and dysplasia and predisposes. Development predisposes gastric cancer. But it's a different cause. Intestinal metaplasia, dysplasia, and predisposes to gastric cancer. Reflex also after cholecystectomy, gastric surgery, antrum is affected. Usually doesn't give rise to peptic ulcer disease, treated by prokinetic agents or bile chelating agents. Defective mucosal barrier treated by H2 blockers or PPI. Occurs due to NSAID. Then and then you have gastritis. It is a form of various forms of gastritis have been depicted, which we have taught already. Type B and erosive gastritis are common, and endoscopy and biopsy are key investigation in all forms of gastritis. Treatment depending on the type of gastritis, and rare forms of gastritis include granulomatous gastritis and foci gastritis, etc. Okay. No, reflux, I thought it was from the stomach to the esophagus, but it's actually from the duodenum to the stomach. Still some antrum is affected. That is a weird thing. Peptic ulcer disease it is defined as acid peptic incision of aliment. Peptic ulcer disease. Acid peptic digestion of alimentary mucosa resulting in an ulcer called as peptic ulcer disease. Corrosive effects of acid with a proteolytic effect of pepsin are responsible for PUD. Duodenum and stomach are the common sites of PUD. Usually they can occur in jejunum and mucous cervical, very dense, ectopic gestational acid mucosa. Types of peptic ulcer. Depending on site, it is chronic duodenal ulcer, chronic gastric ulcer, look at the duration of chronic peptic ulcer and acute peptic ulcer. This is easy one. And nasopharyngeal ulcer, combined ulcer, chronic gastric ulcer, and chronic duodenal ulcer. First inch of the first part of the duodenum, chronic gastric ulcer is a curvature adjacent to acid secreting parietal cells. Combined is gastric ulcer type 2, so injury is asymptomatic also. Non-ulcerative before that. So we'll be talking about Zollinger Ellison syndrome, which is one of the rare causes of peptic ulceration. Non-ulcerative dyspepsia, commonly mistaken as peptic ulcer disease and Zollinger Ellison syndrome. Okay, so non-ulcerative dyspepsia is characterized by symptoms related to upper abdominal viscera. Symptoms may include abdominal pain, bloating, indigestion, nausea, heartburn. Heartburn is a single symptom suggesting of gastroesophageal reflux disease and excludes the diagnosis of dyspepsia. Symptoms related to non-ulcerative dyspepsia is considered when no anatomical or biochemical abnormality is discovered to explain the patient's symptom, and after H. pylori infection, ingestion of NSAIDs is the most common cause of non-ulcerative dyspepsia in pelvic ulcer disorder. Only important point. H. pylori is always associated with histogenic gastritis, which is absent in case of non-ulcerative dyspepsia. In H. pylori, eradication therapy is not recommended. The importance of non-ulcerative is related to its place in differential diagnosis of gastric pain. There is no role for surgery in treatment of this itself. Some of the patients who have been diagnosed as non-ulcerative dyspepsia may have gallstones or esophageal reflux disease. Abdominal ultrasound and esophageal manometry is required to rule out these diseases. I don't think anything is important. Esophageal gastroduodenoscopy should be done in all of the patients with non-ulcerative dyspepsia, followed by biopsy from smoke to rule out H. pylori. First, let's discuss Zollinger-Ellison syndrome. So, Zollinger-Ellison syndrome (ZES) is a clinical triad consisting of gastric acid hypersecretion, severe PUD, and non-islet cell tumors of the pancreas. carcinomas localized to the head of the tumor, and of pancreas, adenoma, wall of the infants. For multiple and two-thirds are malignant. It is associated with MEN1. Yeah. What 1/4 is associated with MEN1? Others are pituitary adenoma and parathyroid adenoma. Pathophysiology of GDS are distinguished from gliadal ulcer are present and are all explained either by action of gastrin to stimulate gastric acid secretion and mucosal growth, or by the action of other associated hormones in the MEN1 syndrome. Gastrin to stimulate gastric acid secretion and mucosal growth. It is acting so compared to duodenal ulcer, this will happen. Gastrin is there which stimulate gastric acid secretion and mucosal growth, or by the MEN1. Clinical features: abdominal pain and POD. The hormones of the syndrome typically occur in more than 80% of the patient. One half of the patient have diarrhea secondary to increased gastric acid secretion. Weight loss and steatosis. Due to decreased pH and inactivation of lipase. Esophagitis from reflex. This will be seen in Surgery syndrome. Investigations to do endoscopy, which demonstrates a prominent gastric fold, reflecting the trophic effect of hypogastremia on the gastric fundus, in addition to evidence of PD. Gastronema and ZDN, Zollinger-Ellison syndrome are always considered and ruled out in patients who have a recurrent or intractable peptic ulcerative disorder despite medication of H. pylori and appropriate antisecretory therapy. Multiple or atypically located ulcers. POD is associated with significant diarrhea. Associated with symptoms of MEN1, hyperparathyroidism or kindred MEN1, large gastric rugae on endoscopy. This is the only thing which is important. Hyperparathyroidism or kindred of MEN1. Atypically located ulcers. It is seen in those patients with other pancreatic or endocrine tumors. Most patients with gastronema have elevated fasting levels. Values greater than 1000 picogram per ml is diagnostic. Secretin test is most sensitive and specific provocative test for gastronema and aids in differentiation between gastronemas and other causes of ulcerogenic hypergastrinemia. Secretin 2 microgram per kg is administered intravenously in serum. Gastrin samples are measured before and after secretin administration at 5-minute intervals for 30 minutes. An increase in serum gastrin after greater than 500 picogram per ml for the basis is associated with gastrin. Secretin is administered intravenously. Serum gastrin levels are measured before and after secretin at 5 minutes interval for more than for 30 minutes. So 6 times I'll do. And increase greater than 200 picogram per ml above basal levels is specific for gastronema. Gastronema in the head of the pancreas, as I told, and hyperrugal hypertrophy. Rugae will be very, very more prominent. Rugae, multiple peptic ulcers. This is ulcerative type of gastroenteritis. Ulcer disease. Treatment is acid suppression therapy with a PPI. Then localization of gastronema is performed before operative intervention is made. Non-invasive methods including CT scanning, MRI, CT, MRI, ultrasound, endoscopic ultrasound, in octreolide scintigraphy, photosetting imaging. Invasive include visual angiography, percutaneous transhepatic pyloric venous sampling for gastrin, and selective arterial secretin simulating test. In patients with resectable gastrinomas, surgical resection is performed that includes tumor resection from duodenum, pancreas, and regional lymph nodes. Tumor resection from duodenum, pancreas, and regional lymph nodes. Total gastrectomy is really indicated, and this is not non-compliant with accessory, or whether tumor cannot be. Okay. I think if you read this much, it's enough. Secretin test, serum gastrin levels, and yeah. Hyperacidity, and then you have chronic peptic ulcer disease. Etiologically, it is caused by hyperacidity. Acid now ulcer is still good for acidity. Neurological causes, you have stimulation of the vagus, which increases the secretion of acids. This is brought by anxiety, worry, hurry, and curry. Very hot stuff if you eat. Those who are worried, they hurry and eat a lot of curry. NSAIDs, they are responsible for gastric ulcer and duodenal ulcer by altering the mucosal defense. And genetic causes, you have family history of duodenal ulcer may be present in a few cases which suggest genetic cause. Patients with O type are more prone for development of CDO because of increased parietal cell population. O blood group has increased parietal cell population. I don't know where I read this. This is actually true. I mean, I can say I read it in Manipal Manual, but somewhere else I had already read about this. Maybe Gaitan or GK Pal. Food habits: spicy food, poor food diet, poor in vitamins, smoking, and alcohol alone or in combination with precipitate the development of chronic duodenal ulcer. Bacteriological causes, you have Helicobacter pylori, a spirotrichal bacteria that has been demonstrated in the submucosa of the antrum and duodenum from the biopsies of the ulcers. It increases the pH by splitting urea and releasing ammonia. Raising pH really results in proliferation of bacteria. Endocrine causes, you have Zollinger-Ellison syndrome, non-beta type cell tumor of the pancreas with hypergastrinemia. Hyperparathyroidism causes increased level of calcium, which stimulates the palatal cell mass, resulting in hyperacidity. So H. pylori infection is there, and NSAIDs is there. So H. pylori infection causes release of cytokinins, polysaccharide, etc. It also causes hydrogen ion and pepsin. NSAID with NSAIDs it called hydrogen ion and pepsin release. And NSAIDs also cause topical and systemic effects. So the hydrogen and pepsin cause mucosal damage. The cytokinins liposaccharide cause inflammatory cascade initiation, cytokinins, neutrophil lymphocytes, and mucosal damage and ulceration. Whereas the topical and systemic effects due to decreased prostaglandins, decreased mucus, decreased blood flow, increased neutrophil, and decreased bicarbonate also cause mucosal damage and ulceration. This is the pathophysiology, I think so. Yeah. Hyperparathyroidism causes increased level of and neurological causes anxiety, worry, hurry, and curry. Anti-mucosal defense, food habits, spicy food. Etiological causes which endocrine causes etc. Then, oh my god, this was not pathophysiology. This is not pathophysiology. Another time pathophysiology. Okay, duodenal ulcer is a cause. Okay. Pathophysiology of duodenal ulcer. This is pathophysiology of peptic ulcer. Okay, duodenal ulcer is a disease of multiple etiology. The absolute requirement for us are acid and pepsin secretion in combination with infection with H. pylori or ingestion of NSAIDs. Although there is a strong correlation between parietal cell and number of an MAO only patient with duodenal ulcers have increasing mean parietal cell number. Whereas gastric ulcer patients do not. Then chronic gastric ulcer, in majority of the patients there is no hyperacidity. Many patients have hypoacidity or normoacidity. Also occur due to defective gastric mucosal barrier. This barrier is a coat of thick mucus which is impermeable to pepsin. Prostaglandins normally present in gastric mucosa do not allow back diffusion of hydrogen ions from the lumen. NSAIDs inhibit the production of prostaglandins, causing a loss of reactive activity. There is no hyperacidity, however defective gastric mucosal barrier, and usually barrier is a thick coat of thick mucus which is impermeable, but in prostaglandins normal presenting gastric mucosa do not allow back diffusion of hydrogen ions from the lumen. NSAIDs inhibit production of prostaglandins, causing loss of productive activity. It can also be damaged by smoking, spicy food, alcohol, reflex of intestinal. Some condition that may predispose to gastric ulceration is age more than older than 40, sex female ratio. Female is more. Okay. NSAIDs, abnormalities, secretion, gastric stress is through delayed emptying, coexisting duodenal ulcer, duodenal gastric reflux of well, gastric H. pylori, cardiac smoking, long-term corticosteroid therapy, infusion, intra-arterial chemotherapy. So classification, you have Johnson types. You have first acute superficial, single or multiple regressions. Then you have chronic. You have type 1, type 2, type 3, type 4, and type 5. This images might just be better. As I see, type 1 is on the lesser curvature of the antrum near the oxidizing central mucosa. Type 2 is with duodenal ulcer. With duodenal ulcer on the lesser curvature of the antrum near the junction. Pericardial ulcer, high gastric, pre-pyloric or channel ulcer. Cardia proximal stomach, hypogastric ulcer, cardia or proximal stomach, less than 2 cm from esophageal junction. These both are same. These both are similar. NSAID is used. High gastric ulcer is cardia proximal stomach, less than 2 cm from esophageal junction. Types 2 and 3 are to be treated like duodenal ulcer because they are associated with hyperacidity. Okay. They're all near the channel, you see. Pre-pyloric or channel ulcer. Giant gastric ulcer is those with diameter more than 3 cm. Generally, it's a commercial symbol of multiple erosions. Diameter more than 3 cm. Typically in a curvature. Malignancy is 10%. High chances of perforation bleeding. Medical treatment heals majority of the cases, 80% of the cases. Re-endoscopy biopsy is must. Gastroenterostomy including ulcer bed and vagotomy for type 2 and type 3 gastric ulcer. Gastrectomy. So clinical features of peptic ulcer, you have esophageal-gastro-duodenoscopy, OGD. Ulcer appears as a crater with or without slough or bleeding in the typical location. In gastric ulcers, routine biopsy is advised to rule out malignancy. In duodenal ulcer, biopsy is done for recurrent cases to rule out H. pylori. So comparison is there. I cannot do this now. Shame. So the thing which you have to know is incidence, Inside is mostly duodenum and gastric. This is duodenum, this is gastric, right? First inch of duodenum, first part of duodenum, less curvature, okay, pain, lower abdominal pain, upper abdominal pain. Accelerating the ulcer, hunger pain, relieved on taking food. Accelerating the ulcer and relieved on taking food. After 1 to 2 hours, the pain becomes severe, burning in nature with retrospinal lesion. Heartburn and water retrospinal pain in water brush. Okay. And just a second, have I been speaking? Yeah, okay. Just a second, my phone is ringing. I'll be right back. Okay, coming back. So chronic gastric ulcer, you have pain occurring on taking food and relieved by induced vomiting. Pain is burning nature as in duodenal ulcer. So it's completely different. Relieved by induced vomiting. In chronic duodenal ulcer, it never occurs in duodenal ulcer till the patient develops pyloric stenosis. Never occurs in vomiting is important. Weight gain will be there and weight loss will be there. This common hematemesis plana is also 40 60 60 40, and there is more hematemesis. More hematemesis in chronic gastric ulcer. Incidence of malignancy never, 2%. On examination, tenderness in right hypochondrium, tenderness in the epigastrium. Up, right, down. Just below the rib cage. Esophageal gastroduodenoscopy. It is diagnostically, it is peptic ulcers, acute and chronic. You have gastritis, you have carcinoma of the stomach, you have esophageal varices ulcers, esophagitis, and biopsy to rule out H. pylori infection. You have brush cytology and biopsy, in which the yield is better. Therapeutic, you have injection of adrenaline into the blood vessel, variceal injection, snaring of polyps, electroevolution of bleeders, endoscopic cystogastrectomy, foreign body removal, percutaneous endoscopic gastrotomy, PEG, endoscopic mucosal resection for early carcinoma of the stomach. So you have gastric outlet obstruction where a meal can detect dilated stomachs and hugely dilated J-shaped stomach. Also shown here. So in long-standing duodenal ulcers, there may be narrowing of the pylorus with stasis of food in the stomach, which is suggestive of pyloric stenosis. Okay. Ring of polyps. Barium meal study, you have duodenal ulcer deformity due to duodenal camp. Trifoliate deformity seen when duodenal diverticum occurs. In general, benign ulcers are smooth and more regular. However, just in the flat smooth ulcer base, in malignancy, the mass protrudes into the lumen or has folds surrounding the ulcer crater. So, our stomach and gastric outlet obstruction. In order to detect them, you do barium meal study. Treatment of CDU, it is to decrease the pain because of its severity by reducing acidity and to prevent relapses. Exploratory tests we already discussed. Wait, it's absolute no. God damn it. I totally missed that. Barium meal study, it's not important though. Yeah, what will you do with whole stomach, gastric outlet obstruction, or what will you do? Dilated stomach, who's dilated reception? What's this? Okay, so you can use for medical treatment ranitidine, but ranitidine is outdated now. You give another medication. It is H2 blocker, the other medicine, but this ranitidine is very much outdated. Um, Famotidine, yes, is as effect of ranitidine. Oxidine along with food, bronchodilator, antacids, and other blocker. This blocker is relapse occur if they are stopped. There's some 80%, 90% healing rate occurs after 6 weeks of therapy. Hydrogen ion antagonist PPI. You have omeprazole, 20 mg to antibiotic once a day for 3 weeks. Within 2 to 4 weeks, healing will occur. Maintenance dose for 3 months. Ismoprazole, lasoprostol, pantoprazole also used. So yeah, pantoprazole 40 mg. I can give omeprazole, but now pantoprazole 40 mg per day for 4 weeks is the first line treatment. Regular this. Diet should be blind, spicy food, caffeine, alcohol, and gas smoking discouraged. Eradication therapy. This is H. pylori eradication. Actually, yeah, I can totally make really funny video for this one. So endoscopy pictures your normal pyloric opening. You have the second part of the duodenum, which is normal, and then normal scamocomal junction at this line. You can see. So bleeding in the duodenal ulcer is shown in here, right here, and chronic gastric ulcer is here. Esophageal gastroduodenoscopy. OCD showing bleeding duodenal ulcer right over here. Diverticulum due to ulcer. Some diverticulum is this one. Then you also have large gastric varices. The patient is also had duodenal ulcer. So surgical line of management, you have surgery which is highly selective vagotomy. First is it is called PCV, parietal cell vagotomy, or PGV. All of these are important. Proximal gastric vagotomy. In this operation, we are not divided at the trunks. Both anterior and posterior are divided, identified, isolated, and preserved. The branches run along the lesser curvature are isolated. The anterior and posterior, which I have told, greater gastric nerves of lateral jet. Branches of the nerves of lateral jet supplying parietal cell masses are divided. Hence, it is called parietal cell vagotomy. The terminal fibers of the nerves of lateral jet, which supply pylorus, are preserved. So it is 5 to 7 centimeter of crowfoot. So advantages is that it is more physiological and with minimal disturbances. No drainage is there, no supply to gallbladder, liver is not disturbed. No diarrhea is there, which can occur in 5 to 8% of the cases of truncal vagotomy, which can be morbid. So again, vega is not divided at the trunks. Both anterior and posterior vega are identified, isolated, and preserved. Their branches, which run along the lesser curvature, are isolated. They are anterior and posterior greater gastric nerves of lateral jet. Parietal cell vagotomy here. So it is important that many surgeons say that HSC is minimum. Hence, it is safe to do gastrojejunostomy (GJ). Mm. Okay, I'm not tired. How long have we been streaming? 2 hours, huh? I don't believe that was that long. How many pages did I do in 2 hours? I believe for 20 minutes I wasn't there. Uh, Maybe even just half an hour I wasn't there. So 1 hour 30 minutes I've been doing. Yeah, an hour 15, an hour 30 maybe. Yeah, I haven't been there. Okay. So next. Do I want to take a break? I'll go until acute complications of optic ulcer. Okay. I'll go a little bit fast. Okay. Disadvantages of HSV is disadvantages. It is not a procedure for prepyloric ulcer. Not the procedure for prepyloric ulcer. It's a easy recurrence rate. Complicated procedure. Experience recurrence rate is not 15%. Rate of lesser curvature necrosis. Lesser curvature necrosis will be there. Total truncal abdominal vagotomy with gastrointestinectomy of Mayo. GG. Paralleloplasty. Early sector vagotomy. Paragraph is present. Hence drainage procedure is not required. GG. Mayo with vagotomy. Mortality of the stomach is lost after vagotomy. Hence drainage procedure. GG in this picture is required because it's a treatment water to gastrointestinectomy. Posterior GG. So yeah, going back, most popular, most commonly done operation for peptic ulcer disease. However, it is important to realize that indication for vagotomy and GG are becoming lesser. Indications are lesser, becoming necessary. Transaction of both vagal trunks at esophageal hiatus and denervates acid production at the fundus of the stomach. It also denervates the remainder of the viscera supplied by the vagus, including biopsy, liver, biliarity, pancreas, intestine, and up to mid transcolon. Total truncal okay. Denervates, it also denervates some of the viscera supplied by the vagus. Up to mid transcolon. Procedure. Anterior and posterior trunks of the vagus are divided just below the diaphragm, followed by a drainage procedure such as gastrointestinectomy. Drainage procedure is gastrointestinectomy. Okay, after that. After vagotomy, motility of the stomach is lost and gastric spaces occur, hence drainage procedure is done. Okay, let's say we do the drainage procedure. Okay. Indication for surgery is intractable pain, frequent relapse, and complications. With the H. pylori negative, gastric outlet obstruction, hemorrhage. Posterior GJ is preferred because it gives dependent drainage of the food contents by gravity. Classically, it is described as posterior vertical retrocolic isoperistaltic loop, no loop, short loop, No tension GJ of the Mayo. PV ring, posterior, vertical, retrocolic, isoperistaltic, no loop, short loop, no tension GJ of the Mayo. So, pyroplasty is before patient. Phoenix and my colleagues. Pyloroplasty. Pylorus is incised longitudinally and sutured vertically. Thus, the pyloric ring becomes incompetent and wide open. Bile reflex gastritis and diarrhea are major problems after pyloroplasty. Not your record. So long as sutured vertically. Pylorus is incised longitudinally and sutured vertically. Pyloroplasty. Thus it becomes incompetent and widely open. Okay. Finlay's pyloroplasty is another procedure where the inverted incision U-type incision is given involving a distal stomach and duodenum and gastroduodenal stroma is created. This type of pyloroplasty is indicated when the duodenum is dilated. Vagotomy and andrectomy. By removing the vagal stimuli and the antral gastrium, entire stimulus to the acid secretion is lost. Hence, it carries the least recurrence rate, but it carries 3 to 4% mortality rate. It is not done routinely. Vagotomy and andrectomy. 3 to 4 mortality rate, not done routinely. Least recurrence rate doesn't even make sense. Okay. Just a second. Which part is the antrum? 1 millisecond. Antrum is anthura till the pylorus. Yes, antrum. Fundus is up. Body. Antrum. Pylorus. I think I got this one a little bit confused. Antrum means full down will be affected. Reflux also full down will be affected. And it will affect the entire kidney and the fundus and body in autoimmune. Okay. In treatment of gastric ulcer, you heal the ulcer and relief symptoms will be seen. Frequent biopsy is done to rule out malignancy. Medical line of treatment can be given for duodenal ulcer in the form of ranitidine, omeprazole, cigarette smoking should be stopped, NSAIDs and aspirin to be avoided. If the ulcer persists after 6 weeks, aim is to eradicate the H. pylori, provided malignancy is ruled out. Then surgery, you can indicate it in gastric ulcer persisting in spite of medical treatment. Yeah, longitudinally it is cut and vertical incisions is made. Incision is extended into the first part of the duodenum and stoma in the pyloroplasty. So you make longitudinal incision, you cut it, and you make a vertical gastroduodenal incision, deepened to open into the mucosa, suture in the vertical direction. Under running of a bleeding gastroduodenal artery can be easily done with this operation. Hmm. Okay. Treatment of gastric ulcer. You have aim is to heal the ulcer and to provide relief of symptoms. Frequent biopsy is done to rule out the malignancy. So, medical line of treatment can be given for duodenal ulcer in the form of ranitidine or omeprazole. Okay, that's it. Cigarette smoking, drugs, SIDs, or medical line of treatment. I'll just mark. Surgery is very thorough, partial gastrectomy. So this is for chronic duodenal ulcer. How much for it? Or in this one, ranitidine, omeprazole, and this here is going to be ordered. Chocolaty or bar. So it is surgery is indicated in cases of gastric ulcer persisting in spite of medical treatment. Bill Roth, one partial gastrectomy. Partial gastrectomy is done including removal of ulcer followed by gastroduodenal anastomosis. It has the least recurrence rate and less than 1%, but mortality rate is around 1 to 2%. Removal of ulcer followed by gastroduodenal anastomosis. Least recurrence rate, mortality around 1 to 2%. Highly selective vagotomy, the pyloric robot is preserved. Posterior GJ Mayo with vagotomy, mortality assessment is last after vagotomy, hence Rennie's procedure is required because the secretary motor. This again I told duodenal incision. Incision development to open into the mucosa. Suture in the vertical direction. Under running of a bleeding gastroduodenal artery can be easily done with this operation. In Heinke Mekulic's Heineke Mecklets. Then Finlay pyloroplasty incision is there, and then stroma is made. Okay, Billroth 1 gastrectomy followed by gastroduodenal anastomosis. This is vagotomy with enterectomy. Full antrum is removed. Vagots is also removed. Billroth type 2 gastrectomy. It is indicated when the gastric ulcer is located on the lesser curvature. Hence, gastrectomy is done below the ulcer and remnant of the stomach is anastomosed to the loop of jejunum loop. Gastrojejunal anastomosis. It is also described as pyelogastrectomy. Gastrectomy is done below the ulcer and remnant of the stomach is anastomosed to loop of jejunum. This thing is removed and this thing is attached to the then HSV, highly selective vagotomy with excision of the ulcer can be done if experience of gastro. Type 4 gastric ulcer is difficult management problem because it involves the entire stomach. It depends on the ulcer size, distance from the GE junction, wherever ulcer should be excised. Most aggressive approach is to perform a gastrectomy that includes a small portion of the esophageal wall followed by a rose and Y esophagogastroduodenostomy to restore the intestinal continuity. Type 4 gastric ulcers that are located 2 to 5 centimeter from the gastroesophageal junction. Distal gastrectomy with a vertical incision of the resection is to include the lesser curvature with the ulcer can be performed. That is pouchet procedure. After resection, bowel continuity is restored with an end-to-end gastroduodenostomy. Okay. Okay, a lot of different names are there. C-sense. Okay, C-sense procedure may be used in stable patient. Killing Madlener operation in unstable ones. Some have even not vacated, leaving the ulcer in place or locally exercising it in conjunction with truncal lobotomy and pyloroplasty. C-sense procedure, killing Madlener procedure, pouchet procedure. Very much important. So, summary: acute, summary is this one. Management endoscopy. First, if you see if it is duodenal ulcer or gastric ulcer. Duodenal ulcer, H2 blockers, PPI for 6 weeks and avoid the irritants. Re-endoscopy after 6 weeks. If the ulcer is healed, then you maintenance dose of ranitidine 150 mg 6 months. If there is relapse, then you go on to active ulcer, where there is you have to test for H. pylori eradication, and relapse of the ulcer persists. If H. pylori eradication or relapse or ulcer, if it is still there, you do surgery. So the other option is gastric ulcer, biopsy to rule out cancer, H2 blocker, proton pump inhibitor 6 weeks, avoid the irritants, re-endoscopy after 6 weeks. If there is a healed ulcer, then you do maintenance dose of 150 mg of ranitidine and active ulcer. If you do biopsy and relapse, you see if it is H. pylori positive, then you do H. pylori eradication. If it relapses or ulcer persists, then you do surgery. Same thing. These both are the same thing. Except you just look for cancer. Yeah, that's it. So complication of peptic ulcer are acute you have perforation, hematemesis and or melena. Subacute you have residual abscess, and chronic you have gastric outlet obstruction, teapot deformity or less contraction of the stomach. Bile, this thing we read now, penetration into the pancreas and carcinoma of the stomach. And that's it. Okay, so I've been recording for 2.5 hours, and I think I thought for 2 hours I can say. I'll take a little bit of a bigger break right now. Longer break. I will continue after 9 p.m. Yes. So yeah, I don't know, my voice is also kind of hurting. I didn't expect my voice to hurt, to be honest. I always thought it'll work out. Yeah, I have to step out for some time. Just a second. I'm thinking if I press stop streaming, no. Let me just put this in scene. Just a second. My camera doesn't get overheated also. Yeah, it's good. Okay, I'll take a break for around half an hour. I'll be right back, you guys. ಅಜ್ಜಿ 9 ಗಂಟೆಗೆ ಬರ್ತೀನಿ ಅಜ್ಜಿ. 9 ಗಂಟೆ 9:30 ಹಂಗೆ ಬರ್ತೀನಿ ಅಜ್ಜಿ. ಬಿಡ್ತೀನಿ ರೀ ಅಪ್ಪ. ಲೇಟಾಗಿ ಹೋಗ್ತೀನಿ ಅಂತ ಗೊತ್ತಿತ್ತು ಅಪ್ಪ ಹೇಳಿದೆ. ಲೇಟಾಗಿ ಬರ್ತೀನಿ ಅಂತ ಗೊತ್ತಿತ್ತು ಬಿಡಿ. ಬರ್ತೀನಿ ರೀ. ಓದ್ತಾ ಇದ್ದೆ. ಓದ್ತಾ ಇದ್ದೆ. ಬರ್ತೀನಿ ಅಜ್ಜಿ. ಬರ್ತಾ ಇದ್ದೀನಿ ತಾತ, 9:30 ಬರ್ತೀನಿ. ಏನಾಗಲಿ ಬರ್ತೀನಿ. ಆಯ್ತು, ಬಿಡ್ತೀನಿ. ಹ್ಞೂ ಹ್ಞೂ ಏನೇನು ಆಟಾಡ್ತಿದ್ದೆ ಆಟಾಡ್ತಿದ್ದೆ ಏನಾಯ್ತು ಇಲ್ಲ ಇಲ್ಲ ಹ್ಞೂ ಹ್ಞೂ ಕನ್ನಡ ಓದೋಕ್ಕೆ ಬರಲ್ಲ ಮಾರಾಯ. ಹ್ಞೂ ಆರ್ ಬಿ ಐ ಹ್ಞೂ 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 ಹಾಂ ನಮ್ಮ ಹಾಂ ಇಂಥದ್ದು ಎಷ್ಟು ನೀನು ಸಿದ್ಧನ ಮಾಡ್ಬಿಡು ಮಗ. ಜಿ ಕೆ ನೀನು ಸಿದ್ಧನ ಮಾಡ್ಬಿಡು ಮಗ. ಹಾಂ ಹೌದಾ ಆಯ್ತು ಸುಮ್ಮನೆ ಬರುತ್ತೆ. ಓಕೆ ಓಕೆ ಹಾಂ ಹಂಗಂದ್ರೆ ಓಕೆ ಓಕೆ ನಾನೇ ಇಲ್ಲ. ಹ್ಞೂ ಏನು ದುಡ್ಡಿಲ್ಲ ತಾನೆ ಫ್ರೀ ತಾನೆ. ಹ್ಞೂ ಓಕೆ ಹ್ಞೂ 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 To be entirely honest, I want to just stay here. I really want to finish acute complications of septic ulcers, but I really am not able to understand how to do this. Maybe if I just exit. Um, okay, I might have to come back again. I'll just come back again with another thing. I will do another stream, but for the time being, I'll do the stream. I'll continue the stream. I'll make another stream. This topic, acute complications, I won't do. I will do another topic. But yes, I will finish.